Welcome to Spine Academy. In this video, we're going to provide an overview of the different cervical spine approaches. This is an excerpt from a broader course on cervical spine surgery in which we provide a high-level overview of the different types of surgery that are performed. If you're interested in seeing the full course, we've left a link in the description. So now that we understand the two different approaches, there are many considerations that we use as surgeons to decide which of these approaches to use. On occasion, we'll do surgeries from the front or from the back or even both. So if you look at an image from the side, once again, this sagittal section where you can see the front, the spinal column, some of the disc herniations that are illustrated here, some ligament thickening, and of course the spinal cord in the middle, it helps just to illustrate the different approaches. And as a reminder, approaches from the front we call anterior, approaches from the back we call posterior. Now, let's talk about the different considerations for how we select one or both of those different approaches. The first thing to think about is the location of the pathology. So pathology from the front, or what we call anterior, or sometimes we use the word ventral, we generally would preferentially use surgeries from the front. Pathology from the back, like ligament thickening, which can also be called posterior, or dorsal pathology, those are all kind of interchangeable names. We often would favor surgeries from the back. So the first rule is go where the pathology is, and that kind of makes sense. Another consideration is how many levels are affected. Surgeries from the front are excellent for 1 or 2 level pathology. So for example, if you had levels like this, surgeries from the front are great. In general, I would say surgeries from the front are ideal for 1, 2, or sometimes 3 levels. On occasion, we will do surgeries of 4 levels or maybe more. I have actually never done more than 4 levels, but 4 levels is fairly unusual. 1 or 2 is like the workhorse. The procedure for that is really an anterior approach. Now, conversely, from the back, you can really approach as many levels as you want. You can go from 1, you can go from the top to the bottom from the back, just making the exposure a little bit longer. So posterior approaches really favor when you have many levels to do. There's some value to doing it from the back. Which levels are involved is very important as well. Approaches from the front, because of some of the structures around it, it's very hard to access above, say, C3 from the front, and that's because your jaw sits there, and it's very hard to kind of get that high to access 2, 3, or sometimes even 3, 4. And then because of where your sternum and clavicle are, it sometimes is very hard to get down to C7, T1. So anterior approaches are really ideal for 4, 5, 5, 6, 6, 7, and certainly 3, 4. You can get to there as well. I would say between C3 and C7, all is fairly accessible from an anterior approach. Getting really high or really low, or so-called extremes of the cervical spine, can be difficult from the front. It's doable, but certainly sometimes a bit more heroic. Going in from the back, you can really access as high. You can get to the skull, which is up here. You can get C1 all the way down to the sacrum. You can do as many levels, as high and low as you need to go from the back. So which levels are affected is another consideration. The next topic is age, and I would say this is a bit soft. I wouldn't say that age absolutely drives us in one direction or the other, but one relevant rule of thumb that I like to use with our trainees is that younger patients tend to tolerate surgery from the front a little bit better. They have less neck pain, their swallowing is a little bit more tolerant. Elderly people often have some pre-existing swallowing dysfunction or some hoarseness, and they're not necessarily as tolerant of anterior approaches in my experience. Conversely, younger patients usually are quite muscular and they have a fair amount of innervation to their muscles, so often surgeries from the back can be a little more painful in the younger patients, and I find older patients tend to tolerate that approach a little bit better. That's not an absolute rule by any means, but age is a relative consideration that I use in my practice. Alignment is another consideration. So if you look at this picture, this person has pretty reasonable alignment. But sometimes people have pathology that looks a little bit different, like they might have some significant disc degeneration, as you can see at these levels over here. With that, sometimes they can lose their alignment or lordosis, and they can get some straightening or even something called kyphosis. When you do surgeries from the front, you can actually put a spacer in there and restore height, as we'll talk about a little later in this video. When you do surgeries from the back, you can't really do a lot to correct the alignment or restore lordosis. So alignment is a consideration that many people use in picking front or back, or sometimes both. Definitely anterior approaches are more powerful for restoring alignment if that's a goal of surgery. Instability is a relative consideration. Certainly we see people with rheumatoid disease, and there's some considerations for going in from the front to kind of help correct it and restore alignment. Stabilization is a little more powerful from the back. So instability is a consideration that varies a little bit on whether it favors front or back. Prior surgery is a real consideration in many surgeries. When people have had prior surgery from the front, going back in from the front is possible, but it can be a little more harrowing because people can have some scar tissue, they may already have some degree of swallowing dysfunction, and those are all considerations when we're thinking about going back in from the front. When the back, for example, if somebody's had posterior surgery, going back in is certainly doable, but you end up beating up muscle that's been beaten up before. Sometimes there's a higher risk of infection with that. So there are considerations for when people have already had surgery in picking one or the other. Swallowing dysfunction. If people already have swallowing dysfunction or hoarseness, I tend to stay away from the front. It's not an absolute rule by any means, but if people, for example, are dependent on their voice, maybe they're singers or something like that, then doing surgery from the front does carry a small risk of some permanent voice change, and so that's something I do talk to patients about. If people have a degree of swallowing dysfunction already, going back in from the front can make that worse. So pre-existing swallowing dysfunction or voice or vocal concerns are a consideration also for front versus back when we're picking a surgery. Infection risk is an interesting one. Surgeries from the front, the way your body is made, have a very, very low rate of infection. It can happen, but it's very rare to have an infection from anterior cervical approaches. Unlike that, posterior approaches have a higher rate of infection. It's still about 1 to 2%. It's not a huge risk, but there is a bit more denervation and what we call devascularization of the muscle, a little bit more of a dead space, and so we see a risk of infection of around 1 to 2%. So patients that are at a higher risk of infection, whether they're immunocompromised, have had prior radiation or other considerations, people that are at a higher risk of infection, I would tend, if possible, to favor doing something from the front. And then lastly, we'll talk about a condition called OPLL, which is ossification of the posterior longitudinal ligament. This is a condition which isn't very common. Certainly in the United States is more rare. It's more common in East Asia. But the presence of OPLL, which is calcification of a ligament that sits right in front of the spinal cord. It is behind the vertebral bodies and discs, but in front of the spinal cord. So in this space right there, people can have calcification or ossification of that ligament. We call that OPLL. And that is one situation where even though the pathology is in front of the spinal cord, we often do not go in from the front, and it's because the calcification, the ossification can be pretty stuck to the lining of the spinal cord and carry a higher risk of damage to the lining of the spinal cord or maybe even the spinal cord itself. So for that reason, when people have OPLL, I tend to favor going in from the back, and most spine surgeons do. Now, even though it's a rare condition, I check for it in everybody, and it is checked for with a CAT scan. So it's common when I see patients that need surgery for the cervical spine to get a CT scan to evaluate this and for other considerations as well. But OPLL is an interesting, if rare, situation that can kind of drive you one direction or the other. Now, this list of considerations for whether you go in from the front or from the back or both is by no means comprehensive. It really, I think, covers the bulk of the considerations that I use when I'm trying to pick different surgical techniques. But understand there is no gospel. You could see 3 different surgeons with the same imaging and get different recommendations because different surgeons might prioritize these all a little bit different. But it helps to kind of know some of the considerations that your surgeon may use in picking a surgical technique that's appropriate for you. Thank you for watching this video. I hope you found it informative. If you've enjoyed it, please like and subscribe. If you have any questions, comments, or ideas for future content, we'd welcome them in the comment section below.